So let's talk about surveillance and UC, long-standing UC, and the prerequisite to perform a good surveillance. I think we can see this nicely illustrated here. The first thing is to have a perfect bowel prep.
Exactly.
And a good bowel prep means like BBPS2 is okay if you can clean anything off. And then no residual inflammation. And here we can accept like small erythema, that is okay. A little bit of edema, that's okay. So it should not be Mayo 0, 0, 0 all over the place. But if you have a lot of ulcerations and it's full of erosions, then it becomes very difficult to distinguish inflammation from neoplasia. So this is the ideal setting. The patient is well sedated. We have a good bowel prep, a perfect bowel prep as a matter of fact. And it's a good indication as well, long-standing UC in combination with PSC. So this is one of the risk factors that qualifies as for yearly surveillance.
If I may interrupt you, if you see a patient with active disease, that means that you will advise to treat the patient until the mucosa is healed, ideally, and then have a second look later on.
Yeah. So it depends a little bit on the situation. It's a very good question, actually, because we are still faced with the patient as such, right? That comes for surveillance. And obviously, it's not like I will pull out my scope and don't look, right? So that's the first thing. So you can still look for things that look dodgy, but anything you biopsy that looks a little bit elevated and comes back as low-grade dysplasia, like with the artificial intelligence, you need to also interpret the histology and say, well, maybe this is not the case, there was inflammation still there. Yeah. But in fact, yeah, if it's like Mayo 3 all over the place or very severe, then I just don't do the surveillance as such. But if somebody comes back after step-up therapy and there is still inflammation, then I would try to do it. Sometimes in that case, I still take the 4-quadrant random biopsies every 10 centimeters. Okay, so let's discuss what we could do. So Triana, you already alluded to the virtual chromatoscopy versus classical chromatoscopy. So because the classical interferes with what we do and with the virtual, then we're going to show this first. And what we showed in the trial is that actually this is a very nice way to proceed because it can highlight the lesions and it detects just as much lesions as it does with chromatoscopy. And just to show you how we work and what should draw your attention, I hope you can appreciate here, which is now at the 12 o'clock position, something that's a little bit whitish from the distance. And these are the kind of lesions that we look for, right? And if you see something like that, then you would try to go closer. You see it's a little bit nodular, so it's like a slight type 2A lesion. But then you come closer. You can find a lot of these lesions in patients with long-standing colitis, and you can see actually that the pit pattern is mostly the same as the surrounding. So most of the time this is then non-neoplastic. But if you look in the center, there's a little bit change in the pit pattern here, right? So this may be something. It's a type 3, and if you look at the top, it's a type 1. So the round pits you can see at the top at 12 o'clock is a clear normal pit pattern, and if we move down, you can see change here, the so-called demarcation line we were talking about. And then we see what's coming up here, which looks a little bit like more type 2 and sometimes type 3. I would warn against just starting to get your snare out in the case of previous UC, although it looks very tempting, and we can show the demarcation line again that David was talking about. And this may very well be an adenoma or at first sight, but very often we find these spots quite numerously in case of quiescent colitis or absence of colitis. So I would always biopsy a larger lesion like this first before engaging into an EMR. We know where it is, so again, the photo documentation is crucial, right? Oh, sorry, so it's probably this. So we take a picture and we describe where it is. It's right at the cecum, so sometimes you can take pictures in referral. And that's one of the advantages of using then also the virtual chromatoscopy, that you can actually just take the reference picture in white light so people know, okay, you can see the cecum there, you know where the lesion is, right? And also take your time, and the quality is everything, and in the beginning maybe take 60 minutes when you start doing this. And I think the nice way to train is to start using it, maybe have a backup with random biopsies for your first 10, 20 cases to make sure you feel comfortable. Then you get to target lesions, you get feedback from your pathologist, And once you've done 20 to 40 cases like that, I think you should be ready to go to virtual Crohn endoscopy.
Okay, great. And while we're finishing up, anything on formal training in Crohn endoscopy?
Yeah, so we have just formulated that with ESG. So the goal is to go 1 or 2 weeks to somebody who does this, to see a few cases, to get acquainted with the technique and everything. And then you just have to start, basically. So first do those 10, 20 cases with a backup of the random biopsies. Then do 20 cases and get feedback from the histology. That's really crucial. And then once you know what these lesions look like and you have shown a good adequacy in neoplasia detection rate, then you can move forward with the virtual Crohn endoscopy, and that's basically it. Anybody can learn this.
Of course, I'd like to stress that. First of all, I've got nothing to declare, and let's start with just defining the problem. So obviously, when talking about a stricture, you need to be aware of what it is. Montreal classification gives you a clear definition. It's a constant luminal narrowing with presplenotic dilatation and/or obstructive signs in the absence of penetrating disease. And then the constrict group, which is actually the Crohn's disease antifibrotic treatment group, has further given definitions for the endoscopic view and for the cross-sectional imaging. So an endoscopic view of a stricture is actually a situation in which you cannot pass the lumen with a reasonable amount of pressure applied without prior dilatation using an adult scope. And then on cross-sectional imaging, there are 3 criteria you need to be aware of, and those are, first of all, localized luminal narrowing, then a bowel wall thickening, and a prestenotic dilatation of the bowel. So how to manage these strictures? Well, the key message is just that this is a multidisciplinary process. And these are the 3 key players. So you see the radiologist, the surgeon, and then the gastroenterologist, who has access to 2 possibilities, and that's endoscopy and medication, obviously. First of all, we'll head off with the radiologist, and his role is actually a dual role. Obviously, it's important for making the diagnosis of the stricture, for ruling out any surrounding problems such as penetrating disease, abscesses, and fistulae. And up till now, MRI enterography is the gold standard for diagnosis of small bowel strictures. And as you can see in the right upper image, again, the 3 criteria must be fulfilled. So that means a luminal narrowing with small bowel thickening and then prestenotic dilatation. And this differs a little bit according to the type of cross-sectional imaging that you're using, and this is nicely shown here in the image. Then the second role, actually, and this is a role that is new, pretty new and ongoing and in development, that is the radiologists can also help us in our decision-making in that way that they can help us differ between an inflamed stricture and a fibrotic stricture. These techniques are new, and I must say that up till now, not a single technique is 100% accurate, so still in development. And some examples are given here. And then you can see some practical considerations, but obviously I've mentioned those, and maybe it would be best that we go over to discussion for the remaining time.
Okay, so thanks a lot, Jeroen. So unfortunately, we have only 3 minutes for discussion, but this GIEQs is very intensive. So maybe first, Philip and Mark, as gastroenterologists, how strict you are about endoscopic dilatation when there's inflammation, because this can be kind of subjective. Do you treat, if you see an inflammatory stenosis, short, do you treat it and then do the dilatation, or how you strict? I know.
So if I can answer, so for me it doesn't matter. There is an inflammatory stricture, yes or no. It's more depending on maybe previous or a transmural imaging that I also would like to see. But if it's most often an anastomosis, whether it's ulcerated or not, that doesn't matter. And also in the published papers, we did not see more complications if the anastomosis or the stenosis was ulcerated.
That's correct. In fact, the risk factors for perforation or complications are long strictures, longer than 4 or 5 centimeters, a very narrow diameter, younger patients, and also maybe there's a concern for patients on steroids, but luckily we don't have them so many anymore.
Okay, yes, Dirk.
Does the type of anastomosis play a role in dilation?
You mean like the Kono S type
or
of
or
anastomosis,
if it's
or?
side to side or isoperistaltic, that it's easier
we were
to
very happy when our surgeons started to do the so-called peristaltic anastomosis, so that we don't have to make that 180 degrees U-turn. That helps for more technical matters, but regarding complications, I don't think that really matters.
Okay.
Yeah, but certainly if you have no surgical report and you have a narrow opening at an anastomotic site, it's very dangerous to go in with a balloon. In the case you showed, we could nicely see through the hole that it was in the direction of the balloon. But if you have a end to side or side to side anastomosis, you may end up having a perforation. And then the other question I had for you, maybe Jeroen, if you don't really see the opening or the lumen behind, would you go for dilatation or carefully, or do you send the patient for imaging before you do the dilation?
Well, it depends on the setting that you have in your hospital as well. I think the way to go is imaging. Fluoroscopy can help during the procedure. You can let your procedure be guided by fluoroscopy if you don't have a clear visualization of the mucosa behind it. But obviously these cases need to be discussed multidisciplinary. I think it's always a balance between the complication risk and the risk of success.
Maybe if you scope a patient for obstructive symptoms, it's better to do an MRI first before you do the endoscopy.
Okay. It's important to be aware of the surrounding tissues, possible complications, presence of associated abscesses and things like that.
Yes. Okay. So yes, unfortunately, we don't have questions from the public. We'd love to continue discussing, but we don't have the time. So thanks a lot, and we will move on to the next session. Bye.